Hi, I'm Javier Jimenez, and I'm going to talk about two topics. The first topic is immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma can spread from a mass of cancer of tumor to other parts of your body, and this process is called metastasis.
Hello everyone, in this video we will discuss about renal cell carcinoma. So renal cell carcinoma is also known as hypernephroma or Gravity's tumor, and it mostly occurs in older individuals, usually between 6 to 7th decade of life, and males are slightly more affected than the females. In this video we will discuss about the types of tumor, we will discuss about the risk factors and the morphology of RCC. Going to firstly the risk factors, one of the most important risk factor is tobacco smoking. Others are obesity, hypertension, unopposed estrogen therapy, especially in females, then exposure to asbestos, petroleum products, and heavy metals. Some familial syndromes are also associated with RCC, especially von Hippel-Lindau syndrome is one of the most important uh, familial syndrome to be associated. We will discuss about this briefly in this video. Now, going to the types, the clinical features firstly. Now, the clinical features, there are three classical diagnostic features of RCC. One is the costovertebral pain, second is the palpable mass, and lastly is the hematuria. And this one, hematuria, is the most important one. This hematuria can be intermittent in nature, can be microscopic in nature. Because it is microscopic, sometimes the diagnosis is delayed.
Application in medicine, immunotherapy is the use of drug to boost a person's immune system so that it recognizes and kills cancer cells more effectively. Several types of immunotherapy can be used to treat kidney cancer. Interferon alpha was the most commonly used treatment option before the era of planned treatment. To study with 1,166 participants compare interferon alpha alone monotherapy with standard target therapy. Interferon alpha is probably inferior to the target therapy tested, sunitinib and temsirolimus.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Pros and cons. Pros: stopping or slowing the growth of cancer cells, preventing cancer from spreading to other parts of the body, helping the immune system to work better in killing cancer cells. Cons: feeling tired, diarrhea, fever, and shortness of breath, rashes, sores, covering more than 10% of the body.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail one or two VEGF targeted therapy, there is a role for IO immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Issues applying Ecuador, according to the data in the National Institute of Statistics and Census, it was determined that kidney cancer is more frequent in men with 2.5% and in women with 0.9%.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So in the let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes in the past. If we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors. So these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population, there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually, there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now, IO therapy has largely been second line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Conclusion: immunotherapy is a current treatment against cancer which in study has been shown to be effective and well tolerated, presenting fewer adverse reactions than conventional treatment. This type of treatment is still being investigated in different types of tumors.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones.
Another topic is Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: hepatitis E is a liver disease caused by infection with a virus known as hepatitis E virus. The virus has at least 4 different types: genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video.
Application image. The hepatitis E virus is transmitted mainly through the fecal-oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with this disease.
Hepatitis E is RNA virus, spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
Pros and cons. In rare cases, acute hepatitis E can be severe and result in fulminant hepatitis, acute liver failure. These patients are at risk of death. Fulminant hepatitis occur more frequently when hepatitis E occurs during pregnancy. Issues apply in Ecuador. Every year, there are an estimated 20 million hepatitis E virus infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E in Ecuador.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure, or a week or so prior to onset of symptoms, and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis, for which other causes have been ruled out, may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients.
Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available.
In conclusion, Ribavirin as monotherapy may be effective in treating chronic hepatitis E virus infection. A 3-month course seems to be an appropriate duration for the therapy. Though a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy.
So hepatitis, meaning like this inflammation of the liver, most commonly comes about because of a virus. These viruses tend to target the cells in the liver, right? And when they get in and infect these cells, they tend to cause them to present these weird and abnormal proteins via their MHC class 1 molecules. Watch the full video on osmosis.org.
Thank you very much.